into it. So my conflict of interest slide, I don't have any relationships with any pharmacy industry. I work for Island Health and the PAD services funded by the Ministry of Health. The objectives for today, just going to be talking about some of the evidence on for PPI efficacy, some of the evidence out there on harms, and then just discussing about discontinuation and just reassessment in our older long-term care population. So I just wanted to first start out, I'm first gonna go over the benefits and the evidence for the efficacy. And the quality of evidence, all the evidence that I'm going to talk about for benefits is from Cochrane systematic reviews, kind of our highest level of evidence out there. And you'll see when we go into harms how the evidence changes. So I ask you, what is the most common indication that you see PPIs for in residential care? Coming out of hospital. Anyone else?
No one can remember.
No one can remember. Exactly, and that is a very great point. That is one of the issues with PPIs is that they're started so long ago. No one remembers why they're on it, or they started it in hospital and they don't need that anymore as they're out in the community. So I'm going to run through what kind of evidence we have for efficacy, and then thinking about for your patients, why are they on this medication? So for the first one up here, you would think a lot of people have started it for GERD, uninvestigated GERD, so those who haven't had scopes or anything. And the numbers needed to treat to benefit are a lot better than what we've seen for our statins. As you can see, number needed to treat to benefit of 2. So their PPIs work really well. So over 70% of people are in heartburn remission, so basically having no symptoms from their heartburn. So these medications do work really well, and we have good evidence to support that. And then I also have the data for PPIs versus the H2RAs like ranitidine, and they're just stronger inhibitors, so people find that they may have better symptom control on the proton pump inhibitors. And to get very pharmacology based, it's just because proton pump inhibitors work at that kind of very last step of acid production where the H2RAs work up here, so people do get some tolerance sometimes because some of these other processes kind of pick up the slack when we block off the H2RAs. So people do find the PPIs sometimes do work better for them, but some people find the H2RAs work just as well. So do you have many people with diagnosis of Barrett's esophagus or erosive esophagitis? Some? Yeah, so some, and then some people, they never get it, it's just uninvestigated GERD, so they kind of fall under that first slide. But I just wanted to show the evidence. It's very similar for erosive esophagitis. The numbers are very similar for how uninvestigated GERD, for the numbers needed to treat to benefit of 2 across the board for healing the erosions and then also providing symptom relief. Where PPIs fall a little bit is in endoscopy negative reflux disease, but it's all, again, just about following up. If you started the medication, are they having symptom relief? That's the one thing for proton pump inhibitors. It's all about, for a lot of these first few conditions, it's all about symptom relief. It's not like we're trying to prevent something from happening. We're trying to maintain symptom relief. So we have something that we can measure and reassess while following up with patients. So for functional non-ulcer dyspepsia, which is more of those people with that kind of, they feel really full really fast, or they have general foregut malaise and those kind of things going on, the PPIs were really no different than the H2RAs in this kind of setting. They haven't really been shown a role here. All right, H. pylori, you see that in residential care very often? Occasional, yeah. So again, highlighting just the evidence, it's great. PPIs help for H. pylori. It's obviously in combination with the antibiotics. The antibiotics are treating the H. pylori infection, and then the PPIs on board because we want to prevent an ulcer from reoccurring or to treat the ulcer that's already there that's been caused by the H. pylori. So you can see that they help to reduce the incidence of recurrent ulcers from 67% down to 13%, so helping to treat that ulcer or prevent future ulcers from occurring. Sometimes when the ulcer has been on board, a lot of the time those HP packs and when we prescribe PPIs, if there is just a simple, uncomplicated duodenal ulcer, normally only need 14 days of the PPI, but if they have a gastric ulcer or if they've had complications from their duodenal ulcer, they may need that PPI for 4 to 8 weeks just to allow healing of that ulcer if they've had an active one with their H. pylori infection. All right, NSAIDs, many residential care patients on NSAIDs. Yeah, so, so this is the data for preventing NSAID-associated peptic ulcer. And where this data, where I kind of put some interpretation here, it's all about what they did in the studies was everyone was on long-term NSAIDs. They gave half of them placebo, and then the other half were given a PPI. And so what they did to measure the ulcers is they scoped every single person and just documented, did we see something that looked like an ulcer? So it wasn't people presenting with symptoms of an ulcer, it was what was visualized on a scope. And so the number needed to treat to benefit was 4. So for every 4 people on a proton pump inhibitor, because they were on an NSAID, you're able to prevent 1 endoscopically seen peptic ulcer from the NSAID. So just a little caveat as to the limitations of that data. It wasn't symptomatic peptic ulcers. It was just what was seen on the scope. And then the last piece for efficacy, I just wanted to mention that NSAID data reflects more of the higher doses of aspirin. It didn't contain things like the baby aspirin or 81 milligrams of ASA, or data like from things like Clopidogrel, and sometimes I've heard about what about prednisone and those kind of things. And there isn't a lot of high quality data out there, so it's all based on individual patient risk factors and things like that when you're considering PPIs for patients, but just knowing we don't have a lot of evidence on those particular patients. All right, transitioning into harms. And so I mentioned our efficacy, great data that these medications work for a lot of our patients. And then the evidence was systematic reviews. Now we're getting into harms. And this is all information that's observational. So there's lots of confounding. It's really hard to really interpret. So I wasn't able to put in any numbers needed to harm to kind of try and quantify these for you. But I will run through the harms and the limitations of the evidence just to kind of get you thinking about some of the harms out there. And I'm not saying these to scare you or say we need to stop all PPIs. It's really coming back to what was said at the beginning. We don't even remember why people are on these medications. So it's just reassessing why are they on it. We're not sure. Maybe we'll try tapering them off and we'll try stopping it. Do they get symptoms? Okay, we know what the indication is now and we want to control those symptoms, so maybe we'll go back on the medication or we'll try a different medication to try and control these therapies, because there are harms with medications and these medications do contribute to polypharmacy. So, what harms have you heard of with proton pump inhibitors? So magnesium? Pneumonia? You hear that one, but I will. Renal injury, yes. All right. C. diff? Yeah. So the first one, I'm going to touch on all of those that were mentioned, so that's great. Osteoporosis, yeah, that's another one. So the first one here I have is C. diff, and so you see as I go through these slides, the information gets weaker and weaker and weaker as I go through. So this is actually a systematic review of 51 studies. They are all observational, and so we may think 51 studies, that sounds pretty good. But I do put the caveat that 37 of these 51 studies were people who were hospitalized, on antibiotics, and other things that increase your risk of C. diff. So it's not purely just PPI versus placebo and the risk of C. diff. So there's lots of confounding variables to really understand what is this risk of C. diff. So when we look at this odds ratio, you would think, oh, there's a relative increase in risk of 65%, but when you think about all those other variables like antibiotics, we know those increase our risk of C. diff, and all the other things that weren't controlled, we're not confident in this estimate. And there was actually a Health Canada warning released about this, and then they actually retracted it and were like, well, the information is quite weak, but it's one of those things. If you see severe diarrhea in a patient, maybe C. diff can happen with PPIs. It could be potential. It's quite rare, but it is something that maybe you might need to consider.
I think one thing is that I said it right at the start. So there might be some association. You might need a little bit.
There might be
other drugs that are causing that, or maybe they're constipating, they're overflowing. There's lots of different things that swirl around. So don't just think about one drug. Think about them all together in relation to what's happening.
Definitely. Yeah, definitely thinking of the whole picture for sure. So another one, fractures. So I heard osteoporosis was mentioned. So this is a systematic review of 9 studies. And there are limitations. These studies were all older women in particular included in these studies. And I kind of say, like, again, lots of confounders. We can't really fully believe this estimate. But if we did think, oh, there's a 25% increase in risk, what does that actually mean? So it all depends on that person in front of you. So if that person, if you looked at their other risk factors and everything that was going on for them, and you said, well, I would guess their baseline hip fracture rate is 1.5 out of 1,000, let's say, and we increase that 25%, it becomes 1.875 out of 1,000. So it all depends on what that person's baseline risk is, and then applying that information to them. But even then, we still can't fully trust these numbers. These are just some associations that have been found with the medications. All right, and there has been a Health Canada warning out about that one as well. So pneumonia was another one that was mentioned. This one's interesting in that it's been linked with the combination of proton pump inhibitors and having GERD. So when you take a proton pump inhibitor, you change that acid environment in your stomach, but you're not changing the actual reflux. So people are still refluxing the contents up. So when you change that acid, bugs survive better. You reflux that stuff up, they colonize in the throat, and then make their way into the lungs. So when they've looked at when people were only on proton pump inhibitors because they were on NSAIDs, there was actually no increased risk of pneumonia. So it's really multifactorial and shows you that there are a lot of different players in the game for some of these risks. And again, there's lots of confounding in a lot of these studies. So it's just getting you thinking about these harms. It's really hard to quantify them, but it's just getting you thinking, what is the indication? Is this really something that they need? This one, I didn't even know about this until starting doing research about PPIs. Quite a large relative increase in risk, 315% if you interpret that odds ratio. But again, lots of different factors go into these patient populations. They have varices and other things going on that make it really difficult. So it's all back to the patient, and do they really even need the medication in the first place? So this was in the news recently. I heard someone mention kidney. This was just February 22nd, 2017. Popular heartburn drug could lead to kidney damage without warning. So I pulled a systematic review that was published in February of 2017. And they found with their review that there was an association with adverse kidney outcomes, but it's all observational data of very low quality. So it was hard to say we need more data really to be confident in the harms that have been seen. And in that one particular study, so this news article just referenced a singular study, not the randomized control, not the systematic review that was published. But in the one trial that was referenced here, when you read through it, you noticed a lot of the discrepancies. There was people with more diabetes and cardiovascular disease and things like that in the proton pump inhibitor side. And then they didn't really account for all the other medications they started. And so there's so many variables that kind of impact how we assess that risk. Acute interstitial nephritis has been shown with PPIs. So the list goes on. And then the other one that I wanted to really mention today was also in the news about a year ago now, and it was about dementia and the risk with the proton pump inhibitors. So again, there is a systematic review that was just published in January of 2017, and they said there were so many methodological issues in these trials that they didn't even give an estimate. But what people see in the news are these one single studies, then they come to you and they're concerned about it. But if they aren't concerned about it, it does open that conversation. Well, maybe we can try to cut back, or maybe we can see if you still have those problems that you had when you started the medication. So sometimes these things can open the conversation, but just knowing that the relative risks that are reported in these studies, there's a lot of information, a lot of confounding, and really hard to know what the true real estimate is for them. All right, and then the last kind of two I have just data on. Like I mentioned, all the previous ones were systematic reviews. Now we're getting into case control studies. So low magnesium and low B12, just things that the data is even poorer here, but just kind of thinking about the other impacts of these medications. And then I have a whole list of all the other ones that have kind of come up at different points with the medications, but the data is even weaker than the information that I already discussed. So recognizing there's lots of limitations, the bottom line is really just why do they need this medication? And it can be quite complex. There could be lots of other medications that they're on that are contributing to a need of a proton pump inhibitor. But there is an opportunity to ask questions and try to taper someone off and see what happens. Do their symptoms come back? This is a very kind of symptom-based condition, and sometimes PPIs are started in hospital and continued when they're not needed, or they had an H. pylori infection way long ago and that's cleared, so they don't need this PPI anymore, and just kind of trying to limit the amount of things they are on. If there's a clear benefit, then that benefit's going to outweigh these potential risks, but there are risks. It's hard to know exactly what the risks are, but they are things that could be contributing to that whole scenario of why someone may not be as good as they could be. So I just have a few little considerations. There isn't any differences among the proton pump inhibitors. There's lots of studies out there comparing different ones, and there hasn't been one to be, this is the best PPI, everyone should be on this one. They're all considered quite equivalent. In the hospital, we just always change everyone to the same one, just therapeutic interchange for these medications. And starting empirically, just that once a day standard dose, and I have the standard doses on this slide, is normally all that's necessary. And then just going based off patient's symptoms, going up to twice a day if their symptoms aren't controlled on a once a day medication. The only time where we go with the twice day is always for H. pylori. We do twice daily dosing, and then Zollinger-Ellison syndrome has crazy doses, which I don't think you probably see that often. So I did put the coverage in here just for anyone who, for any of the residential care facilities that have community pharmacies that provide the medications. So it has changed. So it used to be you had to try an H2RA before you could get PPI coverage. It has changed. That's no longer required. You just have to fill in the special authority form that they have GERD or esophagitis, or they have an ulcer, or they have one of all these other things. So no trial of ranitidine is required anymore. And then they also changed into this reference drug program thing. So I'm not going to spend too much time on it, but essentially the pharmacare coverage is for either rabiprazole or pantoprazole. And then if you did want to prescribe one of these other ones, what they do is they pay for this, and then the patient has to pay out of pocket for the other ones, like the difference in the cost. But you can get these covered if they've tried both of those and didn't tolerate them, or if you have kind of some certain extenuating circumstances why you need one of these other ones. And then for anyone who does practice in primary care without practicing in residential care. Some of them are available over the counter now in Canada. Just an interesting fact. And then drug interactions. So I just threw this in here because clopidogrel is kind of the most common drug interaction that come up with the proton pump inhibitors. But for anyone who's on any cancer, transplant, or or HIV medications, there are lots of drug interactions with those, so always being diligent about that. Try to avoid PPIs with clopidogrel if possible. It has to do, so it's thought that it impacts the metabolism of the clopidogrel. So clopidogrel is a double prodrug. It has to get metabolized twice. So omeprazole impacts the CYP enzymes the most, and the other ones aren't as impacts it less. So it's thought that if you did need a proton pump inhibitor, pantoprazole is the go-to, and to really avoid omeprazole. But if you can get away without using any or using like an H2RA or something, that would be a better alternative.
So effectively it's increasing the dose of clopidogrel?
It's decreasing it. So clopidogrel is a prodrug to become active. So when you don't activate it, then you're not getting as much. Yeah. All right. So my last little thing is just on tapering. So there is a thought, it isn't supported by a lot of high quality evidence, but if you stop cold turkey, there's this thought you could get this rebound hypersecretion of acid. So proton pumps, they covalently stop the acid production, and you have to generate a whole new cell. So it's thought that if you stop cold turkey, they generate a whole bunch of new cells, and then they just get a whole bunch of acid, so that they could be get this quite symptomatic rebound. So it's thought best to taper if you can. So for those who have Island Health pharmacies filling their medications, we do have pantoprazole 20 on formulary, but for those who are in the community, the pantoprazole 20 is actually not covered under that whole pharmacare stuff. But because I mentioned proton pump inhibitors last, they covalently stop that cell and you have to generate a whole new cell, they actually last longer than 24 hours. So you could go to every other day if you have someone on something like pantoprazole 40 and kind of try and taper them off and see how they do. And then just monitoring their symptoms. Did they get symptoms back? And then using kind of the lowest dose that works for them. Maybe 40 every other day is where they need to be to control their symptoms, or maybe you can go down to rabiprazole 10 or something like that. I did have a mention of cost. So some of them, omeprazole and the pantoprazole, actually get more expensive as you go down in dose, which is probably why pharmacare now doesn't cover those doses. So every other day actually saves people money from that point of view, from a cost point of view. And then just a thing to mention, Barrett's esophagus and severe erosive esophagitis are indications for long-term PPI. And then I have the non-pharm up there just for completeness sake. So that is essentially everything. It's all just about knowing why they're on the medication and trialing discontinuing it.
Great, thank you.
Can you taper with the different PPIs? So for example, could you go to rabiprazole 10?
Yeah, definitely. They're all considered therapeutically equivalent, so you could switch to a different one to make it easier to go down to half the dose and just monitor for their symptom control.
Is there any place for using it PRN?
Yeah, so it can be used PRN. There's also other medications that are available that kind of provide quicker relief. So the proton pump inhibitors, some people do use them PRN, or if they know what certain triggers are and that they're going to indulge in that trigger, then it might be better suited for those who are quite aware of their symptoms, because the H2RAs and things like Tums and stuff like that work a bit quicker than the PPIs. So it all kind of depends on the person. If they are well aware, you could technically even go down to PRN.
Is there seriously no evidence for like dual antiplatelet or triple phase antiplatelet? It's surprising given
Yeah, so there isn't any systematic reviews. So there is a couple like singular trials, but no like high quality systematic reviews kind of looking at that evidence. And there's limitations in those kind of singular trials, so it's just trying to focus on the highest level of evidence for that.
Like a lot of our patients. So what is the evidence for?
Well, I would have to kind of refer back, because I didn't quite go over all the details for it to kind of provide a confident answer at this time for that, yeah.
Would the H2 blockers be a safer choice?
Yeah, so for kind of the harms perspective, so the H2 blockers, they've been associated with pneumonia as well, and C. diff. They haven't been associated with fractures, and then they haven't been associated with things like low magnesium. So there's a couple things where they are very similar to the PPIs, but then there's a couple where they haven't been shown to be at the same risk. So yeah, hit or miss depending on the different harms.
Great, thank you.
Perfect, thank you so much.